Next I call upon Dr. Jyoti Prakash Vyas. He's a vitreoretinal consultant at Giridhara Institute. He'll be talking about the applications of OCT in a diabetic eye. So over to you, Dr. Jyoti.
Thank you, Dr. Rahul and KSOS for the opportunity. After all these wonderful talks, I'll be talking about applications of OCTA in the diabetic eye. The first question which sprung to my mind when I first heard about OCTA was that whether it's an essential investigative modality or just a gimmick which is there in the market for us to play with. To answer this query, I just looked upon into the recent literature, and I stumbled upon two recent articles. You can see these are published this year itself. One is the role of wide field OCTA in assessing diabetic retinopathy from LVPI, in which they studied about 150 eyes of 82 patients for different factors, which actually found out whether the disease progression could be staged according to the presentation on an OCTA. So first thing which they looked into was the presence of foveal avascular zone size and the deep versus superficial plexus orientation of the lesions. So they found that the correlation of FAZ was there, which increased with the severity from mild to PDR. So the size of the FAZ increased significantly as the disease progressed, and in all the stages of the disease as compared to a normal individual, the FAZ size in the DCP, that's the deep capillary plexus, was consistently larger across all the stages of the disease. Then came the other parameters which have already been explained in the previous talks, was the capillary non-perfusion area. So if you look at the three numbers here, this is in mild NPDR, the area of FAZ was something which was to the tune of 6.7 millimeter square, which increased all the way till 22.8 millimeter square in PDR cases. Another was the quantitative analysis of FAZ and the CNP for mainly for assessment whether the disease is progressing or not. Now, and also they also added in the element of looking at neovascularization as compared to wide field fundus photography. All put together, if I read through it, you will not be surprised. If you look at it, it will be very visually striking. To the left of your screen, you can see this is mild NPDR, and as you progress toward the right, it's a proliferative diabetic retinopathy. The lower part, you can see in this retina, you have a reasonably good foveal avascular zone with a good peripheral perfusion, and similar is seen in the OCTA photograph of the same patient. As the disease progresses, the FAZ tends to become irregular and gradually enlarges. There are dropouts in the capillaries, and you can see also in the wide field angiogram, you can see gradual capillary non-perfusions increasing. Then if you compare it to the fundus photography, this patient was actually, this is from the same article, this clinically was labeled as a moderate NPDR patient, but when a wide field angiogram was done, they actually found out these were hidden neovascular elements in the periphery with massive capillary dropouts, which turned out to be a PDR and was treated accordingly. Then correlation with visual acuity was also assessed, and the patients who actually showed an increase in the foveal avascular zone also had a significant drop in visual acuity as the disease progressed. So implications for clinical practice: do you clinically use OCTA normally in a case of diabetic retinopathy? The answer would be a blank no, because clinically the judgment of diabetic retinopathy is based on your clinical judgment, how you look at the fundus and how the presentation is there. But this adds to your knowledge, and this as a non-invasive tool, it kind of helps you to understand the disease faster, and your intervention can be planned earlier on as compared to waiting for waiting for the lesion to develop completely. Another article which was published last year was again in diabetic retinopathy OCTA assessment. So they found out that since it gives you a 3D visualization of the entire structure, they found out the key metrics which had to be studied in this. There are more of research related these metrics, but yet to utilize into the clinical practice. They include the foveal avascular zone, vessel density, as was previously talked about in the previous talks, and flow analysis, along with neurovascular coupling. Now, neurovascular coupling here happens to be an interesting concept here, in which we can actually antedate the appearance of a particular lesion prior to any clinical sign of that. That is, we can predict whether the lesion is going to appear in due course of time or not. So in the foveal avascular zone, they looked at the area, the circularity, and the parafoveal vessel density. If you look at this is a very nice picture from this article. To the left of your screen is a normal foveal avascular zone, and to the right is a diseased one. In the left, they actually divide it into 4 quadrants, and it is called a grade 0 capillary foveal avascular zone with 0 capillary non-perfusion. To the right, 3 quadrants out of the 4 show an irregularity of the margin of the foveal avascular zone, along with variable degrees of capillary non-perfusion in all the 4 quadrants. Vessel density, again, as previously mentioned, blood flow and neurovascular coupling. So neurovascular coupling is mainly altered responses are detectable even before visible diabetic retinopathy changes come in. So this is something which is something to look forward to in the near future, because as of now, our basic understanding of the investigative modality and the availability of these tools is not very rampant. It is only restricted to some institutional and large practices. And the other things which are very useful probably are the identification of ERMAs and neovascularization, which are very well delineated. Coming to the 2 cases per se, which I could find out from our recent patients which we have treated. This patient, if you look at it clinically, looks like moderate to severe NPDR with a circinate maculopathy in both eyes. Naturally, you would go ahead with doing an OCT. You can see a massive amount of cystoid macular edema along with a serous macular detachment. Now, I put in this photo deliberately here because here it highlights the presence of significant macular edema will 100% obscure your OCTA picture. You will not be able to judge anything regarding the macular ischemia or comment on the existence of the same. It's similar in both the eyes. Whereas in another case, which was seen to be right eye was showing proliferative diabetic retinopathy just by the looks of it, and the left eye intuitively probably you will think on the same lines, and the patient also had a creatinine of 4, so he was not subjected to an FFA. We directly went ahead, did an OCT which showed a normal macula. We did an OCTA. Here the vision is reasonably good. If you look back, the patient had a vision of 612 N6, and in the absence of macular edema, even now you can see there's an enlarged and irregular foveal avascular zone in both the eyes, which is a silent mention, which gives you a silent hint as to the disease progression as it is proceeding. So now coming to the first question again, whether it's an essential tool or a gimmick. It's actually the title of another article which is published this year itself, and they found out that although the current applications extend extensively to all applications, the main problems are there are no analytical tools which are stratified, there's no strategy which is fixed across different diseases, and various protocols have to be standardized in order to be used in across different institutions and across different trials. So the take home message would be, although OCTA has all these benefits, but it has to be taken with a pinch of salt, that it is yet about time that we go mature on to this investigation, but we need to update ourselves regularly to use it across different indications and for interpreting it reliably. Thank you.
Thank you, Dr. Jyoti, for your well explained and well imaged talk.